Well, hello everybody and welcome to another episode of GUcast. This is Declan Murphy, urologist, here with my co-host, Renew Epen. How are you?
Hello, Declan.
How are you?
I'm super excited about this podcast. It's a good one.
We don't often flag ahead of time on Twitter what we're going to talk about this week, but we did this week.
We did
this week when we saw all this media at the weekend about female surgeons having better outcomes from their patients than male surgeons. We thought, right, and especially when we recognise the lead author on the
I know,
the
we've
paper.
been wanting to have Chris on the show for a while, and he's given us a great reason for it.
Yeah, so that's coming up. Chris Wallis from the University of Toronto and colleagues published one of two really interesting papers in JAMA Surgery this past week, which got a lot of media headlines around the world, showing that, not for the first time, data that patients undergoing surgery by female surgeons have better outcomes than done by male surgeons. So very contentious
And
topic.
Specifically looking at sort of more intermediate and later outcomes, so 90-day and 1 year outcomes.
Yeah, death outcomes even.
Exactly.
Yeah.
But so I can't imagine that there's any bigger news on X or Twitter, but we do have an X League segment.
We do, because Aoife McVeigh is joining us again in studio. Aoife, who potters back every so often to tell us about what else is going on Twitter this week. So Aoife, welcome back. Good to see you.
Yeah, thanks guys. I was going to say, you make my job a little bit difficult because you take every topical, the biggest topic on Twitter, and then end up getting one of the authors of the paper on the podcast, and then take it. But anyway, that's
And then you have to look harder for the
yeah,
other stuff.
have to look harder. That's okay. It's good. It brings good content. But yeah, there's been a bit on X this week. I actually was gonna come. I know last week I said that I found it okay, but I'm gonna take that back because my feed this week was full of lots of nonsense that I wasn't interested in. So I'm back in the not liking X as much. But anyway,
Are you also back
stuff.
in urology training? No. She's
Not
not. She hasn't returned to that extent.
Urologist. But yeah, so the things I've seen this week was the EUREP conference. So that's a European Urology Residence Educational Program.
Yeah.
And that looked really fun. I thought I seen loads of really good stuff. So first of all, the educational stuff looked really good. So they had loads of little courses and sessions. I think even some Australian trainees are out there, which is great that everyone can go. But in particular, this video that surfaced of some of the Spanish residents, a lot of them female, it looks like, having a bit of a party and a bit of a dance, which is always good to see at a conference.
This is at the Europe conference or in Europe somewhere.
Yeah.
They're obviously celebrating Chris's article.
yeah, maybe that's it.
Female surgeons are better, yay.
It's just fantastic.
Yeah.
I'll go watch that.
Very good, all right.
Full of joy after a day of urology training. Great.
Makes me want to go.
Who posted that?
It was
Euros.
Yeah, I think that's a resident in maybe it's in Belgium. I want to
Very
say.
good,
Yeah.
Euros. Keep
Excellent.
posting from that conference. Looks like you're all enjoying yourself very much.
Yeah, so that's sort of the good fun stuff.
Good one.
As usual, Twitter, there was a few bad things that were going around. So something I hadn't mentioned that I picked up a few weeks ago. Can't believe I didn't mention it because it's my two worlds colliding, which is pop culture and the Kardashians and medicine. But Kim Kardashian was found to be promoting a whole body MRI scan, just a screening one with Pronovo. Interestingly, she mentioned that it was actually an MRI that didn't have any radiation, but no MRIs
As opposed to
have
all
radiation.
the other MRIs, yeah.
Anyway, just sort of completely unattainable for most of the public. And it sort of shows why these two worlds should really collide, to be honest. So, that was, seen that come up, thought I'd give it a mention. And then I suppose a sort of bad one, but you can have a sort of good outlook on it, in that there is a orthopedic fellow, I think that's over in Australia, usually from the UK, came to Australia on fellowship, that was sort of pointing out some things that he's found good about working in Australia. And then someone decided to sort of make a crass joke about orthopedic surgeons about it, which I don't think was meant in a sort of ha-ha way. It was maybe a little bit of a jibe, but that was actually called out by some of the physicians on Twitter to be like, nah, not funny. Let's be all nice to each other. So
Aoife, let's read it out because most of our audience are only on audio. So the original tweet was from Simon Fleming, he's got a big
Yeah,
Twitter
he's
following,
got lots,
orthopedic
yeah.
fellow with 50-odd thousand followers. And
Yeah.
he's commenting here that today's NHS must change, blah, blah. He's moved to Australia and he now gets paid fortnightly. So he's just celebrating that. But then this comment from Thomas Woodcock.
Yeah.
And who's Thomas Woodcock?
So it looks like, I'm not quite sure if he is a physician, but definitely works in like the medicine field, maybe in like medical ethics, even in law and things like that. But I couldn't quite figure that out. But either way, seemed to be involved enough to know this pretty common joke about
Tom
orthopods.
Woodcock replies to that saying, what is the difference between an orthopedic surgeon and a rhino? One is small-brained, horny, and charges a lot. The other is an endangered species of the plains of Africa. If you put your pay first, go to work in a privatized health service like Australia. Go now. Oh, gee, that seems...
Yeah, bit mean.
And then, Ria Liang
Yeah,
replies.
of
So
course,
Ria's a very well-known voice, a fantastic female surgeon here in Australia. So what did Ria say?
Yeah, so it looks like she said surgery has benefited from hashtag the operate with respect, hashtag let's remove it, and hashtag hammer it out. Increasingly, we see disrespectful surgical culture perpetrated by non-surgeons, and this is why I'm pleased to be part of the Commonwealth-funded At a Better Culture project. We must do it together.
Very good, Ria.
Yeah, that's the problem with Twitter, isn't it? It gets very trolly and bitter. So
Yeah.
none of us like that, but it still has a value as a platform, I suppose, in drawing attention to topics. But yes, let's be respectful on Twitter and stuff.
Absolutely.
Yeah, a bit nicer. But yeah, and then just to end it lightly, at David Keynes, I feel like I'm always referencing his Twitter, but he posted a really funny video of, it's actually sort of plastic ball. It's obviously got beads in it. And it's one of those ones that you squeeze and one end pops out. And I feel like as he's described, it's the perfect way to describe, I suppose, the pathogenesis of a bladder diverticulum in particular to patients. So it might be a good idea in urology clinics to, invest in about 10 of these. They probably cost about a couple of dollars each. And, you can explain it to your patients pretty quickly. So, yeah.
Yeah, David Keynes, he's a really good value person to follow at Keynes David, and he's got a very good YouTube channel as well, but he's always been a very good and effective communicator in urology, and we've nearly had him on the podcast once, but the timings didn't work out, but I'd love to have him on again. He's a good friend from the olden days.
That's right, a 3-second video says 1,000 words.
Yeah,
exactly
fantastic.
Right. Yeah, well, thanks, Aoife, that's good.
No worries, and I'm really excited to hear the discussion today.
Should be a good one.
Right, shall we go and welcome Chris Wallis? So
we should.
Chris is a urologist at the University of Toronto, and as we gave you a heads up, he's actually very well published in this area, but he published a very nice paper at the weekend, and the media jumped on it, and the headlines were, what do we see here? Patients see better outcomes with female surgeons, studies find, etc., etc. But we'll dive right in and welcome Chris to GUcast. Chris, great to see you.
Great to see you, Chris.
Oh, thanks so much for having me. Great to catch up with you guys.
And congratulations on this paper. Not your first work in this field, but this is definitely very compelling evidence.
Oh, I'm glad it has resonated. I think, this is work we've been doing for a while, but it keeps building, and we always try and, layer a paper on top of what we've already established before. And so I think this has given us a nice incremental step forward in the whole discussion.
Absolutely. And, it's been received very well, hasn't it?
Well, I think so. But as usual with these things, indeed on Twitter and so on, you'll have people calling out obvious flaws they might see in it, having not actually read the paper. But maybe we should do that first and ask Chris to say, well, look, can you tell us what was this study about? What did you find and what are the limitations?
Absolutely. So there's no perfect study, and so we'll be happy to dive into, what the limitations are. But to give a little bit of background, this is work that we've been doing for about 5 years. We started building a multi-surgical cohort to try and understand the effect of socio-demographics on surgical outcomes. And as you guys probably know, there's been a lot of research done on the patient side of things. So looking at, patient age, patient rurality, issues related to gender, sex, race. But there hadn't been as much interest in the physician side of things and the surgeon side of things. And so I was building this cohort back in, I guess, the winter of 2016. And a really sort of impactful study for me came out from Yusuke Tsugawa, who is at the time was a postdoc in Harvard and is now a collaborator of mine based out of UCLA. And he showed that when patients were admitted to internal medicine teams with common diagnoses like COPD or CHF or, those kind of things. If they had an admitting physician who was a woman, they had better outcomes. And so, that got the wheels turning, and we put out our first paper in 2017, which showed that short-term outcomes, and that's things like readmission, reoperation, major medical complications, or even death within the first 30 days, were lower when patients had a female surgeon. I was a resident at that time and went through a few moves and transitions for fellowship, and the work went a little bit on a pause, but we've picked it up over the last couple of years. And so this is probably the third of, I would say, a series of about 6 papers on this topic that we've put out since I've been back on faculty in Toronto. And this one broadens the spectrum. We take it from the 30-day horizons, which are very classic in surgical literature and perioperative literature, to look a little bit more broadly. And so we've looked at 3 months or 90 days, and then 1 year after surgery. And I think increasingly we recognize that the effects of surgery can linger longer than a month. And certainly for those of us who do the big whacks, I counsel my cystectomy patients that they're not going to feel normal for a couple of months after surgery. Even if they haven't had any complications, life's going to take more out of them. They're going to fatigue more easily. Their appetite will still be off. Things might taste funny. They're just not back to normal. And so really broadening that the spectrum of what we consider to be surgically related events, I think is the goal of this paper. And interesting, what we show is outcomes that are very comparable to the 30-day outcomes. So whether we looked at 90 days or at 1 year, our composite primary endpoint, which was death, readmission, reoperation, i.e. return to the OR for the same or related procedure, or major medical complications. And this is an administrative definition, but these are things like unexpected admission to the ICU, need for intubation, dialysis, VTE, MI, stroke, like major, it doesn't quite fall into the Clavian Dindo because of the way that they're reported, but we're talking really here like grade 3 or higher events. And if you had a female surgeon, patients were about 6% less likely to have one of these events. And interestingly, that was mostly driven by a mortality difference. So in terms of a relative effect, patients with a female surgeon were 25% less likely to die at both 3 months and 1 year after surgery. Wow. Now, one of the things people want to know is, what are these surgeries? So we can dive into that if you'd like.
Yeah, let's do that. I think that's a really interesting aspect of it.
Because that comes out straight away, doesn't it? People are saying, oh, hold on a second now. What sort of surgery was happening?
Exactly.
And also, were the girls only operating on the easy cases, Chris? And so I know you'll deal with it, but you could see it immediately.
Absolutely.
People they'd only read the headline, and straight away it's, the girl surgeons in my hospital only operate on the easy cases.
And you guys tried to adjust for this confounder, but it's challenging, isn't it, in this sort of analysis?
Yeah, so there's never a perfect analysis, and so there's always the risk of residual confounding. And we could talk a little bit more about that. But first, just for the context of what this cohort represents. So back when we started in 2017, I built a team of anesthesiologists, surgeons from about 5 different subspecialties, and a couple of general internists. And we sat down and we wanted to pick a, quote, representative cohort of surgeries. Now, you can't put everything in there because the numbers just get unwieldy. So we picked 25 procedures, and we picked at least a minimum of 2 per surgical subspecialty. Now, anybody who does these kind of analyses will know that your power comes not from just the number of patients you put into the study, but the number of events you had. So we intentionally didn't pick only minor things. If you did lumps and bumps and appies and coles and hydroceles, you're not going to come out with any events, and so you're not going to be able to show anything meaningful of any kind. Yeah. So we have intentionally enriched for procedures that are somewhat higher risk. Now, what does that mean? I mean, we're not talking crazy risk here. We're talking like 90-day mortality rates of 1.5% for patients treated by women, about 2.5% for patients treated by men. So these are not crazy high risk procedures. We're not talking, liver transplants, but we're talking things like, a CABG and a single isolated valve replacement, aorta bifem we're talking about AAA repair. We're talking about cystectomies, prostatectomies, bowel resections, hepatic lobectomies, lung resections, wedge resections, or lobectomies.
Cases.
Big case.
We're talking
a list. Yeah.
No, so we're talking like the bread and butter, and that pans out because when we look at where these surgeries are done, these are not just done at our tertiary and quaternary care level teaching hospitals. When we look in Ontario in the context of this study, these are surgeries that are done in hundreds of hospitals. So this is a generalizable cohort. We've also included the more bread and butter, APIs, choles, TURPs, and equivalent procedures across other surgical specialties. So, I think it's not everything. You can't have everything because you're just going to be overwhelmed with cases. As it is, statistically, these are very hard models to run because there's a lot of complexity. We have a lot of covariates to try and provide some reasonable risk adjustment. And we're talking 1.5 million patients, give or take, in these cohorts, 1.2 to 1.5, depending on the specific research question and what we're having to exclude for the purposes of a particular study.
I mean, I think that kind of does put that argument to rest. These are major complex cases, major oncological cases that have a significant risk of morbidity, mortality, not just in the immediate postoperative period, but down the track as well.
And that's why I think the later time points are very relevant, aren't they? That's very meaningful. Are these patients having a mortality issue is obviously probably the most important endpoint, and to still detect a difference there is extraordinary, really.
And Chris, why do you think that difference is there a year out from surgery? I mean, do you think it's the intensity of follow-up? Is there a difference between males and females in follow-up technique?
So this is a great question. This is, you're asking me to step beyond the data I currently have and postulate a bit, and I'm like super happy to do it, but I just want to make really clear to everyone that this is a bit of this is an informed opinion rather than a evidence-based statement. So I want to lay a little bit of context for how I'm going to approach this. So you guys may know John Berkmeyer's work when he videotaped surgeons in Michigan doing bariatric surgery. And there's a really fairly famous New England Journal paper where the surgeon's skill, as rated by their peers looking at anonymized videos, was strongly associated with 30-day complications. Most people don't know that there's a follow-up study to that paper that was published in JAMA Surgery that looked at 1-year outcomes. And surgeon skill on this Likert scale was no longer predictive of outcomes. So I think that's important to contextualize how I think about these data. I don't think this is, for the most part, what's happening inside the OR. I don't think this is a technical thing about what's happening in the OR because, most patients who die related to surgery don't actually die on the table, right? They die because of some complication that happens in the postoperative period that isn't recognized early enough. And that's where we get into this notion of failure to rescue. And so the idea that if you identify small deviations from a normal postoperative course and you can act on them, you can avert larger complications and mortality events later on down the road. So I think the concept of failure to rescue definitely comes into play here. Not to give away all my future research ideas, but I also think there are differences in what happens before surgery as well. And so we know from numerous studies across all of medicine that women take more time with their patients in counseling, in clinical visits. The communication styles are different. And there's good systematic reviews that show that female physicians get more, not just biomedical information from their patients, but more psychosocial information from their patients. And so I think they understand a patient's context and priorities going into surgery, probably on average better than the male surgeon does. And so particularly for those of us who operate in, preference sensitive areas when there's multiple alternative treatment approaches, that decision to go for surgery, is arguably really important. And you can think through this, and if you have the same number of patients who are destined to have a bad event you can change your event rate by not operating on some of them, right?
Yeah.
So people who are not going to benefit from surgical intervention, but at risk of harm, if you charge forward into the OR, those people are going to show up on your M&M list and reflect poorly on a surgeon's outcomes, whereas you can, potentially avert that outcome and improve the patient's, quality of life potentially by avoiding the OR. And it's not an easy thing necessarily to say, but as a surgeon to come to the conclusion that, the best thing for you is for me to not treat you, maybe that kind of thinking and decision making is more common in female surgeons. There's that old adage of the surgical cowboy who charges into places where they maybe ought not to be, and so I think there's a really probably nuanced and multifaceted aspect to this. The last thing we should acknowledge when we're trying to think about why is that the culture of surgery historically has been difficult or off-putting for women. And so if you walk through this thought experiment with me, let's hypothetically say that all the distribution of ability to be a surgeon is the same amongst male and female medical students. We're equally likely to be a good surgeon independent of your sex. But because of historical and cultural reasons, it's a bit harder for women to get into surgery. So let's say we take the top 10% of male medical students into surgery and the top 5% of female medical students into surgery. And that would represent a much smaller discrepancy than we actually observe in most surgical specialties, right? We're not talking 30% women or 35% women. We're actually talking much smaller. So the barrier, the hurdle is actually probably much larger. You could just expect then, not based on any actual difference in the underlying distribution of skill, but the average woman in surgery would be better than the average man in surgery. The best man and the best woman would be equivalent. The 5th percentile man and the 5th percentile woman would be equivalent, but then there would be no more women in surgery, and there'd be another whole set of men who are lesser skilled, and they would drag down the average. And so I that's a very hard thesis or hypothesis to test or prove, but sociologically, I think it has to be true.
I agree. That's what we were speculating on this morning.
Yes, that's right.
In our multidisciplinary team meeting, we were talking about this paper, and I speculated just like that. I said it's such a broad thing because so many surgeons are male. There are very good male surgeons and very bad and very in the middle. And maybe we're only getting the cream of the crop with the female surgeons that I certainly work with. But then is that disrespectful because, okay, let's say we flipped it around and we had a very broad pool of female surgeons. Is that the explanation for why, because we have a bigger breadth, that we might get more variability? I don't think it's necessarily so, because one of the other interesting things is in the same issue of JAMA Surgery, and we'll put these links in the show notes, there's another study, there's a study from Sweden specifically looking at outcomes following cholecystectomy, and very similarly showing that female surgeons had better outcomes in terms of complications, including important things like bile duct injuries and so on. And Chris, very like what you just said, I was intrigued by this invited editorial that went with these papers from Martin Almqvist, who's a researcher at Skane University Hospital in Lund in Sweden. And he points out that evidence has suggested these three things: that female surgeons are more likely to use patient-centered decision-making, I think this is just what you're saying, more willing to collaborate, and more carefully select patients for surgery. He's saying that there's already evidence out there that shows these three things are an issue, and he speculates that these differences alone might translate into different outcomes. So I think a lot of the publicity that tends to go on stuff like this focuses on, is it hard cases or easy cases? So in other words, surgical skill or experience or something. But I think you've pointed that out, and that's what's really important here is multiple things, and then the rest of us could probably learn from these observations that other expert researchers have pointed out that the rest of us could be doing. More patient-centered decision-making, more willingness to collaborate, better rescue strategies, as you point out, and selecting patients for surgery. So it's not straightforward, but I think the data is the data. There's definitely a difference for whatever it's going to be, whether it's the smaller skill set, the smaller pool of top female surgeons, whether it's these other factors, or whether there is case complexity that hasn't been well confounded, as you say, residual confounders that can't be well accounted for in the study.
I mean, I think it's important because not only, I mean, it highlights that, as we've always suspected, that while technical skills are very important in surgery and for achieving long-term good outcomes, the non-technical skills are also just as important.
Absolutely. And I mean, one of my mentors would say it's the decision, not the incision. And, I think it is really important to think beyond or to open our definition of what a surgical skill set requires, right? And I really, hope that these data are taken in that light by male surgeons. When I published the first paper, I was a resident, and I got an email from a faculty at a different university in a different specialty, but a physician that teaches residents who said, if you think women are better surgeons than men, you're probably not cut out for this, and you should drop out. And it was copied to my residency program director at the time. So, we see that. Defensiveness is easy here. Yeah. But I think what I'm hoping for is a little bit of a growth mentality and a willingness for introspection and say, you know what, I've got something to learn and I can do better for my patients. This data doesn't mean you're doing a bad job. I'm not, telling Declan Murphy or myself or any of my male colleagues that we're intentionally harming patients. But I'm saying, we can do better, and let's try and identify ways that we can do better so that all surgeons treat all of our patients as best as we can. And so, the goal is to go from these kind of epidemiologic data to a better understanding of what's actually driving it, and then make that something that's teachable, something that's learnable so that we can all improve.
Yeah, and that's important because, not every patient can be treated by a female surgeon. There's just not enough of them around.
And that's what we want to talk about in the last few minutes, Chris, to pick your brains on it, because I was just reminding myself of what proportions of surgeons are female nowadays, which remains depressingly low. But I think in the UK, approximately 13% of all surgeons are female only, and it's very variable, only 7% of orthopedic trauma surgeons. I think only about 10 or 11% of urology. This is at consultant level. Here in Australia, in USANS, our Urological Society, I think about 13%. Maybe it's about 13% of surgeons
Sweden
are
is
female.
impressive.
In Sweden, yeah, about one third of general surgeons are. But of course, all this data is also showing a much higher proportion of female trainees are coming through, and hopefully they will all be translating into consultant ranks. So I think this issue of more gender balance in making sure these surgical specialties are attractive for top female trainees to want to come and be surgeons is very important. So I'm interested, first of all, in your strategies for that. I'll say here, actually, in Australia and in the UK, of course, we have female presidents at the moment. We had a great moment at our USANS conference this year when we had, Joe Creswell, the BOUS president down here, celebrating Helen O'Connell, the USANS president, taking up her role here. So this happens. This is really helping, I think, the visibility of training. So comments generally on the workforce, if you don't mind. The second thing I want to come on to is because, like you, myself and Renew, do a lot of big GU oncology surgery, a lot of urologic cancer surgery. And one of the things I really like about robotic surgery is I think it is a great democratizing tool, because open pelvic surgery certainly, and laparoscopic pelvic surgery, is physically arduous, as is some major orthopedic surgery, physically arduous. I think that's one of the great things about the robot, is it takes away a lot of that. You're sitting in a console, very comfortable. It's not going to be something that if you physically find it difficult to do something because you're small-bodied and so on, that it can be a great democratizing tool. So maybe some of the technologies can help with that. And although myself and Renew did a big open surgery case together yesterday, I was like, look at these little hands are great for getting down to this tight pelvis. So we still do some open surgery. But so your thoughts on workforce and technology? Yeah, so I think the first thing to say is that I don't consider myself an expert here. So I don't think I'm, I have thoughts, but I don't consider them, particularly,
I'm struggling for the right word. I don't consider them by any means like a final word or a expert opinion. It's more just one guy's thoughts on the subject. I'm better in terms of, the actual data behind differences in outcomes. But when we think about demographics, I think the real question is, what are we trying to achieve? And overall, I think when you look across the whole healthcare system, there's pretty good data that the better our workforce resembles the patients we're trying to treat, the better care we will deliver. We'll be able to align with patients' priorities better. We'll be able to meet them where they are. And so this, today we're talking heavily about sex and gender. This also reflects race, ethnicity, disability, other characteristics. But, the best we can get our urology surgical workforces to resemble our patient population, the better care, I think, as a field we will be delivering. So in Canada, we have a very small residency force in terms of urology. We have 35 residents a year or something, which means that there's wild swings from year to year in terms of gender representation. In Toronto, we have 4 to 5 residents a year. We have at times had as many as 3 or 4 of them female at a time. It comes and goes. I would say there's dramatically more women in urology training programs now, I think, than there are at the faculty level. And one of my sort of armchair observations has been that there's kind of a leaky pipeline phenomena, and it starts quite early. And so I've seen a lot of great female trainees go into private practice kind of circumstances. We would call it community practice in Canada, but rather than sticking in the academic teaching centers, they're going out into private practice sort of situations. And I think even within academics, it's well documented that the progression of women through the ranks and into positions of leadership has been relatively poor, even given the proportions of involvement. So I think it's great that we're getting more women into urology and into surgery, but we need to make sure that they're not just into our field, but they're able to really have an important voice at the table and be in positions of leadership and positions of power, because you run the risk of tokenism when you have people who are included in the group but not given any real power to act. And so, that goes to, hiring decisions. It's great for a hiring panel to value diversity and want to have diverse candidates. But if you really want a diverse outcome, you actually need diversity on the evaluating panel, on the hiring panel, rather than the hirees. And so I think that kind of a mindset shift needs to happen. And we need not just more women as, trainees, but we need more women in all the positions of power. You're highlighting, we're in a good position right now with USANS and BAUS having female leadership. But 1 year is 1 year, and we've had probably a century of men in power, and people react aversely when I say things like this. But if we were to have 25 years straight where we said there's going to be no men in leadership positions and it's only women for the next 25 years, I think our organizations would be better off. But B, we wouldn't scratch the surface of undoing the historical imbalances, right? Men will jump at the fact that, that will hold, many potentially, deserving men out of positions of power, as if that hasn't been the case for 100 years already with the genders reversed. And so I think it's great to get women into our fields, but we need to make sure that they have the opportunities to advance their careers in the way that they want once they're in. In terms of the technology side of things, I think at the end of the day, it's the way I approach it, at least, is I do 85% robotic surgery, but it's just a tool. Some of the best trainees I've worked with, both open and robotically, have been women. And I've never been in a case with a female surgeon as an open case where they have been physically limited in a way that I thought I can just muscle through this and they're struggling. you know, even when there's like mass involved, there's like a finesse and a nuance to it. You know, one of my friends is a female arthroplasty surgeon who does mostly hips. And she's, I don't know, 5'2" and not very heavy. And like, she can dislocate the hip just fine. So I think the whole notion of, you know, physical limitations is probably less relevant than, you know, the cultural and societal barriers. I don't see a reason why, you know, women can't physically do any of the operating that we do.
Well, let's go and ask her, what height are you? Quite slight.
About 5 feet.
Yeah, because I've made that comment before, Renu, about the physical side, because a trainee of mine said it very forcefully to me one day. I love doing surgery. She was very good, but I'm going to do stones because I don't like pelvic oncology, physical surgery. So, you know, and it was at the start of the robot era, obviously. But it's horses for courses a bit as well. But what do you find as a very good open surgeon and robotic surgeon? I
mean, I certainly think the robot has made it much easier, but I think that's true for men and women. I mean, from an ergonomics point of view, from, you know, the days of, you know, trying to see a prostate that is not destined to be seen but felt, going from that to doing this beautiful robotic surgery, you know, it's changed our field. You know, but I think even with the robot, you do have to watch your physical sort of, you know, your posture. I've been told many times that my posture sitting on the robot is terrible. And that's something that I have to actively work on. So I think the robot has changed our field in many ways, but I think it's true for both men and women.
There you go. And as Chris nicely said at the very end, yeah, maybe there's something. It's clearly not the big thing. It's not the big thing on the big topic we're talking about today. There's obviously lots of these other great reasons, much of them addressable by culture and.
But I think, I mean, everything that Chris said is very true. You know, I think it's not just enough that we get more female trainees and females becoming urologists, but I think it's important that we get them in positions of influence and leadership. And I think that's why people like Jo Creswell and Helen O'Connell and even people like Ria Leanne for RACS has set such a great example. It's that old saying, if you can't be what you can't see. You know, it's important to have these women in those positions, and the lessons that they can teach will trickle down the line, you know, to our trainees and our medical students for both men and women. So I think Chris has made some great points.
And Chris, your co-authors include some very well-known voices like Arga Van Sales. I don't know her personally, but I love listening and watching to her videos. And I've loved seeing some of the really positive reactions to this piece of work as well. So congratulations to you and all your co-authors and everyone else who's chiming in on this. And
JAMA Surgery, who seems to embrace this topic, really. Lots of publications in recent years, many of which you've contributed to, Chris.
Yeah, well, I appreciate you guys' interest in this. And I'm going to, as a teaser, tell you to watch this space because we've got another paper in the next 6 to 8 weeks that I think you will find very interesting.
There you go. We couldn't resist it. A bit of a teaser. Come back for. We'll have to get him back
Repeat
again.
on the podcast. Yeah.
Yeah, exactly. Well, great work. Fantastic. We love this topic. We hope you, as our audience, enjoyed this as well. Aoife, you're moving from urology to radiology, but you've listened very intently to this. What are your thoughts on this?
I
think medicine, because it's not, as Chris said in his opening comments, this actually, his interest in this comes out of non-surgical issues on better outcomes for female physicians.
Yeah, I think, like I said, the paper is absolutely great. It's something I've long suspected, but I think, especially as like a female that was in surgery before, a lot of the times, I suppose what we're describing, well, what female trainees are described as can sometimes be like a little bit hesitant or maybe underconfident, but maybe we should reframe that as looking at the bigger picture, considering all the different factors. Like, it's actually not hesitancy, it's actually making potentially a better decision for the patient. So it's nice to maybe flip the coin on that and be like, actually, your female trainee might not be hesitant, it's more that they're making
healthy level of caution.
Yeah, but I know radiology have issues as well with females in the workforce too, and there's a lot of push to get more radiology training. I'm not sure what percentage it is exactly, but yeah, like it is a bit tough being a female in medicine, but hopefully it's getting better. And I agree with Renu, like you can only be what you can see. So I think keep pushing more females in the sort of faculty big positions, and will inspire more young female medical students and trainees to be like, I can be that. So yeah, it's good.
And Chris was just about to say something. Sorry, Chris.
Oh, I was just going to say, I bet you, if you're at all like me, I actually want my trainees to be a little bit hesitant. The thing that scares me most is that like super confident
Completely agree.
trainee. You worry that they don't even know what kind of trouble they're going to get themselves into. And I find it like so confidence inspiring when the resident or the fellow is like slightly cautious and you have to push them a little bit and be like, you're good, like go for it. It's so much nicer. Like I'm junior faculty, so I haven't been doing this for a super long time. So it's nice to not have that fear that they're going to make some wild and crazy move that you're going to have to try and undo the effects of. And so I find it so, like, I'm so appreciative when the trainee is just a little bit cautious.
There you go.
Fantastic. Great.
That was a great chat.
I did enjoy that. Chris Wallis from the University of Toronto, thanks so much for joining us. The links are in the show notes. Thank you, Aoife, for joining us as well.
Thank you. That was great.
Great to have a bit of Kim Kardashian on GU Cast again. Seems like ages.
She's been missing for a while.
Long overdue.
Feminist hero as well.
Yeah, exactly right. And stay tuned. Please do subscribe, of course. Do leave us a nice review and rate us. We're enjoying the increased content we're able to do now with our partnership program, and details of our partners are on the website as well. So thank you very much to everyone for supporting us.
And Declan, you're going to be doing some location shooting.
Oh, we should say that.
You need to mention that.
Yeah,
keep an eye out for
we do love our new studio.
We do
here in Melbourne, but now the conferences are back. We're out and about. Next week I'll be at the ERIS meeting, the European Robotic Surgery meeting. I'm not sure will there be all that dancing, Aoife, that they were doing at the Europe meeting, but ERIS is on in Florence next week, so we'll do a report from there. And I'll be
EANM is on, and
we'll
be doing some cross correspondence with them. So there's lots of great stuff to look forward to.
Exactly. Stay tuned. Talk to you soon.